everyone, welcome to DMS100 Introduction to Diagnostic Imaging online lecture. So what we'll do is go through some of the slides here, and I'm going to go over the information in the slides and give you a little additional information. So what is diagnostic imaging? So diagnostic imaging and radiology kind of a lot of times go hand in hand, however there is a difference between the two. So diagnostic imaging is an information tool that expands the knowledge of physicians and patients and the practice of medicine. It refers to a variety of different non-invasive procedures or methods for identifying and monitoring diseases or injuries. These are very beneficial to patients. I mean, we talk a lot about being able to see inside of the human body and how beneficial that is. Prior to diagnostic imaging procedures, they weren't able to see what was going on with patients. A lot of times, if it was serious, they would actually have to do exploratory surgery to try to figure out what was going on. So, diagnostic imaging has been huge in identifying and monitoring diseases and injuries. We use detailed images that are produced by diagnostic imaging in the procedures that we use to help give the doctors and the patients more information about our anatomy, where it is and what's going on with it, the structure of the patient's body, and some of the function of how the organs work inside. Especially the function. That was something that we were never really able to see before, but due to diagnostic imaging, that's an option now. So one of the things that you'll notice, especially in some of the hospitals, is they used to be called radiology departments. They're actually moving away from calling them radiology departments and now being called diagnostic imaging departments, because radiology kind of goes back to x-ray and fluoroscopy, where diagnostic imaging can refer to everything from ultrasound and MRI and CT that, with MRI and ultrasound, they don't use radiation. So it's kind of more of a broad descriptive overview. So when we talk about using these non-invasive procedures to be able to see things, when you look at this here, I mean, obviously you can look at this patient and see something's going on, right? We don't necessarily need an x-ray to tell that this patient has a broken bone. But it's hard to determine where the break exactly is and how to realign everything without imaging. So if you look over at the x-ray yourself, you can see the break here. Obviously, we would use multiple views in an x-ray to kind of see exactly where the break is, if it's, the fracture is more anterior or posterior, so that the orthopedic surgeon can realign the bones so that they heal properly. They can get them back in place where they need to be. So obviously something like this, it's a little more obvious, but having x-ray is still beneficial for, putting the bones back into place. There's a lot of times that without imaging, though, the doctors don't have a clear understanding of diseases within the body. So it's harder for them to determine what's going on without some sort of diagnostic imaging. If we look at this x-ray here, this is a knee x-ray, and this is a healthy, normal knee. You can see the outline of the bones, everything looks structurally well. This x-ray over here, if you look at the back, can you see how it's kind of looks like somebody took a bite out of it almost, right? This bone has deteriorated. You've got this nice clear line on the posterior portion of the knee here, but on the posterior portion here, it's jagged, it's missing some of the bone. Now, this is a patient that has osteosarcoma. Now, the symptoms for osteosarcoma are pain off and on, worse with activity or sometimes at night. There sometimes is swelling in the area, and if it's in the leg, the patient may have a limp. So think about that for a second. How many times have you had similar symptoms and not gone to see a doctor? Or gone to see a doctor and they didn't do any imaging? Now, not to make you think that if you start having these symptoms that it's osteosarcoma. It could be you walk too much. You overdid it in exercise. Your dog ran into your knee. There's a lot of different things that could cause these same symptoms. But the difference is, without imaging, the doctors aren't going to be able to see this and know what's going on with the patient. A lot of times it's the first line of defense to see an injury or illness. So radiographers are the individuals or technologists, depending on the modality, who take the images. Radiologists are the ones who interpret the images. Some other physicians do as well. A lot of orthopedic surgeons will interpret their own images, and radiologists will never even look at them. It depends on the site where you work and things like that. But a lot of people confuse radiographers and radiologists. So the radiologist is a physician, is an MD. They're the doctor that's interpreting the images. So they're going to diagnose different medical illnesses or injuries within the patient. And then sometimes they'll plan and implement treatments and therapies. Most of the time that's passed off to the specialist or the doctor that's treating the patient, but radiologists will often recommend additional imaging or additional procedures that that patient needs to have done. Diagnostic imaging can also be used to guide surgical planning. A lot of times physicians order imaging ahead of time, especially CT, MRI, and general x-ray, to map out what they want to do for surgery. They can use measurement tools so they can decide if they're replacing a hip, what size replacement hardware they need. Also for surgeries on the back, they can decide exactly where they want to go in, what procedure they're going to do, and they can use those images as a reference right in the surgical suite while they're doing the procedure. They're also used to, diagnostic imaging is also used to follow up on surgery. A lot of times they'll use ultrasounds to check the gallbladder after surgery, different things like that, so they can make sure that the surgery took well. Also with CT and general x-ray, they're all used to verify that procedures went well. And then again, monitor the outcome of therapeutic procedures. So after rounds of chemo treatment or things like that, they'll use imaging to verify if the treatment's working. So diagnostic imaging denotes that ultrasound, MRI, and CT are now also performed in radiology centers and departments along with traditional x-ray or radiology. So that's why I said earlier that they're kind of getting away from calling them radiology departments, and now they're often referred to as diagnostic imaging departments. Diagnostic imaging is a key tool in the early diagnosis and prevention of disease. It's really important, especially in today's managed care. Managed care essentially just means to control the rising cost of healthcare. Managed care focuses on preventative healthcare. They've realized that it is cheaper to prevent illnesses and diseases than it is to treat them. So a lot of times they're using diagnostic imaging for those early identifications of disease and illness to try to help prevent it so they don't have to treat the patient, or if there is something going on, they can start the treatment sooner. Mammograms are a big example of that. Mammograms are free to patients over the age of 40. Insurance does not charge for them. They consider that a preventative service. So, they're checking to try to find any type of breast cancer sooner so that they can treat the patient, and it'll be a little bit easier and have a higher success rate. There's other diagnostic tests that they'll do as well, like they do CT lung cancer screenings. They also do cancer screenings in nuclear medicine and PET scanning to see if cancers are staying contained to an area or if they're metastasizing or moving to other areas in the body. There's a lot of new minimally invasive surgical procedures that are emerging that can be performed on an outpatient basis, and a lot of times those are used with diagnostic imaging procedures. Now this is helping, again, in that managed care and saving money for the hospital and the patients because they don't have to stay overnight, which is a huge cost. So we use CT and ultrasound a lot for biopsies. So if they find a mass or a tumor and they want to test it to see if it's cancerous, they can go in with ultrasound guided biopsies. They actually watch the needle go all the way into the mass, and they'll take a sample to test it. They also do similar things with CT and MR to try to help diagnose things. They also use C-arm or X-ray guided for procedures such as like pain clinic procedures, lumbar punctures, things like that. They'll use X-ray to guide the needle in to make sure that they're in the right place. So by combining these types of therapies or procedures with diagnostic procedures, the healthcare systems save a lot of money because, one, they're not actually doing a full-on surgery. It's minimally invasive, and the patient can go home that day without staying in the hospital, which is a drastic reduce of cost. So the history of medical diagnosis and diagnostic imaging. Radiology began in the first decade of the 1900s after the discovery of X-rays by Professor Röntgen. His name was Wilhelm Conrad Röntgen. A lot of people look at his name and call him William. It's not William, it's Wilhelm Röntgen. He discovered X-rays in 1895, and he won the Nobel Peace Prize for his work in 1901. So they started in 1895, and then by World War II, the development of radiology had grew rapidly. And I'm not going to get into this a whole lot because we'll talk about it in the next module as well when we go over radiology. So this is just kind of a little overview until we really delve into it next week. So the invention of the digital computer and new imaging modalities like ultrasound and MRI have also been combined to help create this huge explosion of diagnostic imaging techniques over the past 25 years. The growth has been so rapid due to these new developments that we're using now. So this is a picture of Wilhelm Röntgen, the man who discovered X-rays, and this image over here is actually the first X-ray ever taken. This X-ray is of his wife's hand. So as you can see, it's pretty dark. I mean, compared to the X-rays that we have today, this is horrible. However, going back into 1895 when they had no way to view the human anatomy, this was amazing. It actually took about 90 minutes to take this hand X-ray. So that's a lot of radiation that we're giving the patients. This little bulge right here is actually her ring. She had her ring on when they took the X-ray. So in the beginning of radiology, we used film cassettes. The primary exam involved creating an image by taking those X-rays and focusing them through the body part of interest, so if it's the hand, the chest, the head, and directing it onto a single piece of film that was inside a special cassette. So in the early days, a head X-ray could take up to 11 minutes of exposure time. That means that they were pointing radiation at that patient's anatomy, like the head, for 11 minutes. That's a lot of radiation, especially when you compare to how quick X-rays are now. If we're taking an X-ray, that exposure is actually made in milliseconds. So just that timing alone is greatly reducing the dose to the patient. So X-ray dose today is as little as 2% of what it was for that 11-minute head exposure 100 years ago. So remember that in the early days, a head X-ray could take 11 minutes of exposure time. You might want to remember that for the future. Further modern X-ray techniques, both analog film systems and digital systems, have significantly more spatial resolution and contrast detail. So I'll go into what spatial resolution and contrast is in just a minute. What they do, though, is they help improve the image quality, allowing the diagnosis of smaller pathology that really couldn't be detected with some of that older technology. Those technological advances have really helped being able to identify pathology, injuries, and diseases in patients. And this next slide is an example of that. So when we take these two images side by side, this is an image from the early 1900s, and this is a digital image. So you've got film here, and then digital here. And look at the difference in the quality. For one, just the soft tissue in general. So if you look at this one here of the digital image and you follow this down, look at the definition of the soft tissue of the hand. It's very clear. The borders are clear. You can see everything. You can't see where the soft tissue is on this anatomy except for here and throughout the wrist here. So it obviously shows you more of the soft tissue, which is really beneficial in case there's maybe metal fragments, glass fragments, or lacerations that we'll be able to visualize on that digital image. The other thing it really shows you is a clear definition of the bone. Again, here, it's really hard to see the borders through here and in here. There could be little underlying fractures in there that we really wouldn't be able to see very well. In the tips of the fingers here, the distal phalanges, you can't see much, but everything here is nice and clear. So we're able to better diagnose injuries, fractures, and things like that, or small pathology. It makes a huge difference in the quality of the image. Can you tell if this is an adult or a child in this image? The answer is it's a child. And the way we can tell that is the growth plates. So if you look here, here on every digit, and here, see where those bones are separated like that? That is called the growth plate. That's room for the child to keep growing. So in an adult, you're not going to see these here. You'll have joint spaces, but for the most part, the bone's going to be fused together. And I can tell just by looking at that this patient is about 3 or 4, and this patient's about 2 or 3. And the reason I can tell that is based on the carpal bones. So these are the carpals. We have about 8, well, we have 8 carpal bones, and this patient only has 2 and 1 right here starting to form. So babies are actually born without their carpal bones, and they start to grow as they age. So usually about 1 a year up until the age of 8. So this patient has about 3.5, and it's not exact science, but it's something that I've kind of played with over the years and looked at when I have images of children, and it's usually fairly accurate. This is another example of spatial resolution. So what it refers to is the ability of the imaging modality to differentiate between two objects. So low spatial resolution technology will be unable to differentiate between two objects that are relatively close together. So when we go back and look at this image here, this one has low spatial resolution, right? It's hard to differentiate between the white, gray, and black, where this one has a lot of contrast and spatial resolution. So there's a large window of whites, grays, and black. There's a lot of different shading involved. So the more shading you have, the better spatial resolution that you're going to have on an image. And it can help differentiate between the two objects, which are the bone and the soft tissue. These are some early x-ray machines, and they're very primitive. This one here, you've got a man who's taking absolutely no precautions. That's very close to the equipment. So this is the either radiologist or radiographer. I'm not sure exactly who they were back then, if the doctor took the images, but this patient is standing here, and they're actually holding the cassette along with this patient here, which is absolutely, there's some exams we still have the patients hold them, but not like this. The machine's coming right in here, right up next to the patient. We've determined now that that actually causes more radiation to the patient, having the machine this close to them. So obviously he's at a high risk of radiation damage because he's standing right in the same room and very close to the machine. Same here with this person. He's got, if you notice here, so he's got it's a lead glove that they use, so he's protecting his hand, but his face is right here. The radiation source is coming through here, through the patient, and coming right out on this film here. So all of that extra radiation that's coming by that film and passing through there is going right to him. Fluorescent screens were invented, so They involved the use of fluorescent screens and special glasses so the doctors could see X-ray images in real time. So imagine this, for example. This was like, so you could kind of visualize it almost as like binoculars, but there were special glasses that you'd look down into this tube almost, and you could see live images with X-ray. But the problem with that was the doctor was staring directly into the X-ray beam, and the eyes are very sensitive to X-ray, so they were getting a lot of exposure to radiation to that sensitive body part, so it was a major problem. But in 1946, George Schoenander, I do not know if I pronounced that right, I'm sorry, but Schoenander, he developed the film cassette changer, which allowed a series of cassettes to be exposed at a movie frame rate of 1.5 cassettes per second. So prior to the film cassette changer, you could take one exposure, and it was only as fast as the person coming out to change the cassette. So you'd take an exposure, then you'd run out in the room, and you'd put a new cassette in, and you'd take another one. So there's going to be a good 10 seconds in between images, because that's just as fast as you could get it out there and change out the cassette. But when he invented the film cassette changer, what happened is he made a system where the cassettes could be quickly changed with a lever or a button, and the patient or the radiographer didn't have to manually remove the cassette and put a new one in. That way it sped things up, and you could get 1.5 cassettes per second instead of one every 10 seconds. And then by 1953, this technique had been improved on again to allow a rate of up to 6 frames per second by using a special cut film changer, which was really beneficial when they were trying to image anatomy in real time. They wanted to be able to see how things were functioning, and if they could only get one image every 10 seconds, it wasn't beneficial. So it improved with the film cassette changer going to 1.5 cassettes per second, and then in 1953 it was even better with the 6 frames per second with the cut film changer. So these are some older images again that kind of show you how close these individuals were to the radiation. So the early Crookes tube that was from the late 1800s, this is the Crookes tube in here, and I'm sorry, this image is really hard to see, but that's what they used to generate the x-rays, was a Crookes tube. So the standing gentleman over here is actually using a fluoroscope, which is what I was talking about earlier, where they actually look into the machine to see live x-rays. So he's x-raying his hand right now with this. So he's getting the radiation to his eyes, and he's getting the radiation to his hand. There's no precautions, no lead aprons, nothing like that, no distance. And then the seated man here, he's got a cassette down here, a film, and he's placing his hand on that plate to take an image. Again, no precautions against the radiation exposure. They honestly didn't even know about the hazards at that time. I mean, it's kind of like, when people first started smoking, they didn't realize that it could cause lung cancer and cause all these damages. The same with X-ray. They didn't know anything about it, so they didn't know they needed to protect themselves. Contrast medium is something that we use frequently now. It was a huge development with the application of pharmaceutical contrast medium. What that did is it finally helped us be able to visualize organs and blood vessels for the first time. So we could take an image, but there's certain things like the gallbladder and bile ducts and arteries, blood vessels, things like that were really hard to visualize. But once we started using the contrast medium, we could see them on images. Contrast medium or media and agents can also be referred to as dye. So a lot of times they'll call it contrast dye or X-ray dye as well. It was actually first administered orally or via an injection vascularly between 1906 and 1912. So if you're ever asked when was contrast medium first administered, you're going to want to say between 1906 and 1912, or if it asks for any year within that time frame, that would be the correct answer. Wink, wink. Alright, so like I said, it allowed doctors to see the blood vessels, digestive system, and gastrointestinal system, as well as bile ducts and gallbladder for the first time. These this anatomy is really hard to visualize on a plain x-ray, and I'll show you some pictures right now. So this first one here is kind of labeled. This is a picture of the abdomen. So you've got here the liver. I'm sorry, I know the screen's a little bit smaller than what it normally is on a projector, but the liver's here, but it's really hard to visualize. You've got the right kidney here, the left kidney here. You can kind of see a shadow of it. The bladder's down here. Now, the stomach's right around here, and your intestine. The intestine you can see a little bit, like you can see the black is the air. So you can see a lot of times like fecal material and air, but you don't get a clear outline of it. But if you look at this image here, where we've, this one we've put contrast medium rectally so that we can see the large intestine. The white is the contrast. So you can see it filling up this intestine here, and then there's also air in there, which kind of will help visualize everything a little bit better. So this contrast medium was inserted rectally. This contrast medium visualizes the kidneys, the ureters coming down here, all the way down into the bladder. So this contrast medium was actually injected vascularly. And then we start an IV and we put it in that way. Because our kidneys filter everything out, right? So the kidneys are going to filter out that contrast, and then you're going to see it empty down into the bladder through the ureters. This is actually something that has to be done very fast, and I'll go over that in fluoroscopy a little bit more. This is the stomach. So we have the patient drink the contrast to be able to visualize the stomach. But again, the contrast looks white, air looks black. So on a normal image, contrast is always going to appear white and air will always appear black. Now this is contrast in the joint space of a shoulder. There's a needle coming in right here. The doctor puts the needle right into the joint and then injects contrast to verify that they're in the joint space. Now this contrast looks black because we can actually invert or reverse the images, and it's done on a machine post-processing, and the radiologist sometimes has a preference. So instead of it being white, they just manually turned it to look black. So this is not air, and I know that can sometimes be confusing, but normally contrast would be white. So like I said, it really helps to be able to visualize anatomy that we wouldn't normally see. We wouldn't be able to see the joint space, the capsule of the joint surrounding it. We can't visualize the stomach in great detail, the intestines, or the kidneys on a regular x-ray. We need that contrast to be able to see the function. Another invention that really helped progress radiology was the image intensifier. So in 1955, the X-ray image intensifier was developed, and it actually allowed the pickup and display of X-ray movies using a TV camera and monitor. So what it did is it converted low energy radiation into visible light. So that was for the first time we could actually project our X-rays onto a TV and view everything live. This is really beneficial, especially for vascular, like you can see here. So this is blood vessels in the heart and then the brain. Now, we would have never been able to see all these vessels with the contrast in them without having that image intensifier. So in 1960s, the fluorescent system, which had become quite complex with different mirrors and optical systems. Remember how that guy was looking into the glasses on one of the very first fluoroscopy units and he was getting direct radiation to his eyes? The fluorescent systems, when they used those mirrors and optic systems, what they were doing was trying to minimize the dose to the patient and the radiologist. So they were looking at mirrors instead of looking directly into that beam. So that was a step up, but then, you know, we went to the normal image intensifiers. So together with the cut film changer that we talked about earlier, that could give us 6 frames per second, and then the image intensifier, it opened up a way for us to be able to see, like I said, these blood vessels. So that was the new subspecialty known as angiography. So it allows us to view the images of blood vessels of the heart and the brain, as well as many others. Nuclear medicine studies. Sometimes people refer to nuclear medicine as radionuclide scanning. You really won't hear it too much, but just know that the book says sometimes it's referred to as radionuclide scanning. Nuclear medicine was first done in the 1950s, and what's unique about nuclear medicine is it uses gamma cameras. So with X-ray and CT, they use radiation to get the images. With nuclear medicine, it's not radiation, it's gamma cameras that are using. So the actual machine, the cameras, aren't emitting radiation. What they do is they put in very low levels of radioactive chemicals into the patient's body. And then when they scan them with the gamma cameras, those radionuclides are taken up by the organs of the body. They emit that faint radiation signal, which can be measured or detected by that gamma camera. So in nuclear medicine, the machine itself doesn't emit radiation, the patient does, essentially, in small doses, but it's absorbed by the different organs in their body, and they can visualize things so they can help diagnose patients. SPECT scanning is a form of nuclear medicine. It's a type of procedure. In this one, the gamma camera rotates around the patient and takes pictures from a lot of different angles. Then the computer reformats everything into a tomographic or cross-sectional image. So it's very similar to CT or PET scanning, but it's actually still considered a nuclear medicine procedure. So SPECT is an acronym for Single Photon Emission Computed Tomography. So I would remember that as well. SPECT is an acronym for Single Photon Emission Computed Tomography. And I know it's kind of confusing because even though it's nuclear medicine, it's got computed tomography or CT right in the name. But because it uses, again, a gamma camera instead of radiation, it's considered nuclear medicine. Ultrasound. So in the 1960s, the principle of sonar was developed, mainly during the Second World War, and then they started to apply it to diagnostic imaging. The process of ultrasound involves placing a small device, which we call a transducer, which is the handheld component that sonographers use. They place that against the skin of the patient near the region of interest, whatever they're looking at, whether it be the heart, the kidneys, bladder, anything like that. And then what happens is the transducer produces a stream of inaudible high-frequency sound waves, which then will penetrate the body. They go into the organ that we're trying to visualize, and they bounce off, or echo back from those internal structures back to the transducer, and it kind of contours the organs so that we can visualize them. So the waves are received by the ultrasound machine and turned into live pictures with the use of computers and reconstructive software. So that transducer, like I said again, is going to emit those sound waves. They're going to enter the patient's body by the organ. They're going to bounce off that organ, come back to the transducer, and that transducer is going to turn those into images. Doppler ultrasound is just a little bit different. It's still ultrasound, but Doppler is used to estimate the blood flow through your blood vessels by bouncing those high-frequency sound waves, or ultrasound, off the red blood cells. So just a regular standard ultrasound will use sound waves to produce images, but it can't help you visualize the blood flow. So Doppler essentially is used to look at blood flow through your blood vessels, and ultrasound more of the organs. So just make sure you know what the Doppler shows blood flow. Digital imaging was kind of born around the 1970s. That's when the first clinical use started. CT scanners were invented right around then, 1970, by Godfrey Hounsfield. He was the person who invented CT. I would remember his name as well. CT was originally started in the 1970s. It was invented by Godfrey Hounsfield. So the biggest thing that helped CT come to fruition was the image intensifier TV systems and digital technology like computers. So CT is not possible without the use of computers. A large majority of the conventional x-ray systems that we have in the hospitals have been upgraded to digital technology. Most hospitals today have what we call DR imaging. It's digital recording. Some of the smaller facilities haven't. They still have CR, computed radiology, and I'll break down the difference of those in just a minute. We also have something called phosphor plates. This is something that you can add on to older equipment. So it's actually like a plate that traps the energy inside and then requires an immediate processing step to release that stored information. So it's converted into a digital picture, which we call CR as well. So digital versus analog x-rays. So they both use x-ray photons. With analog, the x-rays go into the cassette and they interact with the silver halide crystals, which then produces a latent image. So it puts that latent image on the film inside. What you have to do then is take that latent image and you have a chemical process to get that image out. It takes a few minutes per image. Then you finally get that visible image and you have to have it stored in a large file room. So there's a lot of downfalls to that. One, time. One, cost, because film is expensive. And two, storage and transfer. So you have these large file rooms that you're storing everything in, and it's not easy for patients to get that information to different doctors. So with digital, you still have x-ray photons, but instead of interacting with the silver halide crystals, they're striking a sensor, creating a surface electrical charge. Then they're converted to digital for the digitized image. There's a sensor that's transmitted to the computer, and then the image is produced in seconds. And then all of those images are either stored on the computer or in a PAC system, which is an online storage system. So the nice thing about that is you're able to just transfer all of those images to a doctor instead of physically having to carry films into a radiologist room. You can send them electronically. If you need to send your images to 10 different doctors, you can do that all electronically without having to mail images or reports and things like that. And it's a huge time saver. I mean, these images are produced in seconds, where analog took minutes to perform. That means we're able to x-ray faster and take care of more patients. Benefits of the digital technology to all x-ray systems. So using digital, we use much smaller doses, and then we're actually getting a higher quality image than we would with film. There's a lot more spatial resolution. Remember that? The difference between the whites and the blacks. So digital imaging gives us a bigger scale of white, gray, and black. So it's going to help be able to visualize more. The difference too is digital images can be enhanced and manipulated with computers. We call that post-processing. We have to have an adequate technique used to get a good quality image to be able to post-process it, but we can go in there and we can invert it like I showed you earlier, turn the white to black and black to white. We can flip it. We can lighten up the image or darken the image. We can annotate on the image. We can put what side it is, what body part we're doing. We can put notes. We can rotate them. There's a lot of post-processing that we can do on the images. Like I said before, they can be sent via a network so that we can share that information faster and help assist in the diagnosis. Digital images can be archived. They can be put on CDs so that patients can easily transport them. They can hand carry them to their physicians as well. So they're easy to retrieve at any point to use as a reference, maybe to compare to newer imaging. And it's been a huge benefit for mammography. The higher resolution images that we have now with digital technology have allowed us to see smaller breast cancers a lot sooner, which is helping patients get diagnosed earlier, which is allowing us to start treatment to help have a higher success rate. Okay, so going back to computed tomography, sorry, I don't know why I couldn't say that, computed tomography. So CT imaging, sometimes people call it CAT scan. It's either referred to as CAT scan, CT, or computed axial tomography. It was invented, again, like I said, in 1972 by Godfrey Hounsfield in England. So make sure to write that down. 1972, Godfrey Hounsfield invented CT. In the very beginning, Hounsfield used gamma rays to try to produce the CT images, but then he later just moved on to x-rays. So what he has is a detector mounted on a special rotating frame with a digital computer that helps create cross-sectional images of the object. So it's kind of like a difference of an x-ray, you're looking at, one structure. With CT, it's like looking at a loaf of bread standing on the end, and you can pull out one slice at a time and inspect that area, and then put it back and look at the next section. So in the very beginning, in the early 1970s, when he first invented CT, one scan took hours to acquire a single slice. One scan. And then it took over 24 hours to reconstruct this data into a single image. That's a long time. So the patients had to wait a long time. We use CT a lot for stroke protocols now, and the biggest thing with stroke protocols is we need that diagnosis fast. We need to see what's going on. So even though this new technology was great and amazing, it still took a whole day to be able to see what was going on with the patient. Now, a single image takes less than a second, and the images are reconstructed instantly. So it's really fast. There's not a delay in treatment for the patient because of the imaging. Like I said earlier, the invention of CT was made possible because of the computer. We wouldn't have CT if it wasn't for the digital computer. So these are some of the original, this is one of the original CT scanners from 1974. So this was just a head scanner. You can see here that nothing bigger than a head is going to fit into that. And this is today's modern scanner. So this is what we call the gantry. The hole is much bigger, so we can fit all of the, all of the anatomy in there. Obviously, we've got an LED display. We've got a lot more buttons here. I mean, this was manual foot pump to move it. We've also got over here like a power injector for the contrast medium that we use. So big difference between the original head scanner and the modern CT scanner. MRI was initially investigated in the 1950s. This is not, however, when it was first starting to be used in diagnostic imaging. That's just when they started to investigate the principles of MR. So MRI, or MR, people refer to it either way. It's magnetic resonance imaging. So MR stands for just magnetic resonance. MRI stands for magnetic resonance imaging. It doesn't matter which one you call them. It just depends on who, people just feel more comfortable with one or the other. So it was again researched in the 1970s, and the first MR imaging prototype were tested on patients in the hospitals in the 1980s. In 1984, MR imaging was cleared for commercial clinical use by the FDA, and its use throughout the U.S. has spread ever since. So I know that I threw out a lot of dates there, but if they ever ask you in what year MRI was first utilized, you would want to say 1984, because 1984 is the year that it was first cleared for clinical use by the FDA. So 1984 is when MR first started being used in the hospitals. The development of MR is attributed to Paul Ladabor. Again, I'm sorry, I suck at names. And other scientists at the Thorne EMI labs in England. A lot of different scientists have been involved in the invention of MRI, but he gets most of the credit. This is an MRI scanner, so very similar to a CT scanner. They don't look much different on the front end, but they are a lot bigger on the back side. So this is kind of the end of the introduction. Like I said, we're going to go into each one of those modalities and break them down into much more detail, but this section is just going to kind of give you an overview. So make sure you use the Kahoot links in JetNet to help study for the quiz. When we do Big Blue Button, I will also be able to use that time for maybe going over Kahoots if possible. If you have any questions or concerns, don't hesitate to email me or reach out to me.